That's neurodiversity. So many people prefer to say an autistic person, an autistic patient. So I'll stick with that unless I'm quoting. That's when I'll say a person with autism. So I've got two definitions here for what is autism. And I got these latest definitions from the American Psychiatric Association, DSM-5, including the definition from the Center for Disease Control and Prevention. And you'll find from those definitions, the key thing is to do with communication. The first definition is saying autism is a developmental disability characterized by atypical social interaction. So social interaction on its own, that's some kind of communication. It could be verbal, non-verbal, still it's communication. And the second definition from the American Psychiatric Association says that autism spectrum disorder is a complex developmental condition that involves persistent challenges, again in social interaction, speech and nonverbal communication, and restricted repetitive behaviors. And you can see from that definition, all the three main terms there are about communication. Even the behavior, when the behavior is restricted, when a behavior is repetitive, an autistic person is trying to communicate something with you. So if you understand why they are behaving in that way, then that's communication. We must understand that the effects of autism and the severity of symptoms are different in each person. So what we mean here is when you see one autistic person, the symptoms, the characteristics, everything on that one person is different from the next autistic person you are going to see. It's never the same. They are different. As much as non-autistic people are different in all aspects. And the third explanation as part of the definitions says that a diagnosis of autism now includes several conditions, and that used to be diagnosed separately. So autistic disorder, pervasive developmental disorder, not otherwise specified, and Asperger syndrome. These conditions are now called autism spectrum disorder, hence the word spectrum. It's a range of this. It's not only one specific condition. There is often nothing about how autistic people look that sets them apart from others. But autistic people may communicate, interact, behave, and learn in ways that are different from most other people. I understand that some autistic people, they need help. So it ranges from those people we know they can hardly help themselves if there's no one even to help them to go out of the house, if there's no one to take them to school, if there's no one to help them even to sit and do certain things. But it stretches all the way to what you call high flyer autistic persons. These are some of the people we know in this world who are billionaires by now, engineers, technicians, doctors, neurosurgeons. These are high flyer autistic people. So it's a range. And it all depends with the type of the autistic people you are meeting in your organization. So what is double empathy problem? What we mean is when we are talking of communication here, double empathy simply means that the autistic people, as well as the non-autistic people, both parties, when we communicate, We must be very clear. So, autistic writers have been talking of empathy being a two-way street for many years, meaning that communication may break down due to differences in language and comprehension. And remember, we are not saying the burden of communication should be on the autistic person. Even the non-autistic person should make sure that they send their message clearly to the autistic person on the other end. So it's a bi-directional, difficulty that we face as a society. And it's not a deficit on the part of the autistic person. And this was research was done by Professor Milton, and I was fortunate to be his student just last year. He has been advocating for, that research should also include autistic people in whatever we do, instead of leaving autistic people in research. We have to involve them from the beginning because they must tell their story. And this is part of the neurodiversity movement I was talking about earlier, that whatever we do, we want to hear from the autistic people. And in the future, on these presentations, I should be able to bring in autistic individuals to talk to you so that you can hear their lived experiences, which is a great thing. So in a nutshell, communication is a two-way system. So if it's in your organization, make sure that on your part, you make things clear to the autistic. As much as you want the autistic, to send their message to you, to communicate with you. Now, on many autistic people use compensatory strategies to mask their overtly autistic behaviors when spending time with others. But you see, they do this because they want to fit into the social surroundings. So when they come in your organization, autistic people, some of them, and especially females, girls, they are very good at camouflaging this. You don't see the autism clearly because they can blend in, they can suit in. These are like coping tactics. There are so many reasons to do that. They want to make friends. They don't want to embarrass themselves. They want to make you happy, or they just want things to move on. So they adopt a constructed neurotypical persona in order to seem socially competent and confident around peers. It could be at work, it could be anywhere. Even when they come in a hospital, they might still camouflage and hide their overtly autistic behaviors. And it's so difficult to pick up. But then this may lead to burnout. And imagine trying to live someone's life all the time. That is a huge task. It's so difficult. It can lead to suicidal tendencies or thoughts, because once depressed, this can lead to suicidal thoughts. It leads to loss of self-esteem because they are not trying to be themselves. They are trying to be someone all the time. And as well as in clinical settings, there is a result of missed or late or questioned diagnosis, because what is presented here is not them. It's not the autistic real person. It's actually their camouflaging. They are masking or using coping tactics. So this is something, again, which is very common on autism research currently. So characteristics of autism spectrum disorder fall into two categories as well. And but you can see category one is social interaction and communication problems. That's all embodies communication here. And that includes difficulties in normal back and forth conversation. They find that challenging just to have a normal conversation non-autistic people can just have. There is reduced sharing of interests or emotions. So you might look at them, they come into your organization or in your clinic or in your units, and you don't see any interest, you don't see any emotions. And again, it's really dangerous because you can end up picking something wrong, which is not them. Also, they face challenges in understanding or responding to social cues, such as eye contact and facial expressions. So I can actually tell that I'm talking to you and I can tell the state you are in because I can read your facial expressions, but some of them cannot do that. So you should not mistake that and think possibly they're arrogant. Someone might think, well, they could be on drugs, there's something wrong, but they could not be like that. It's simply because they can't read facial expressions. And also, there's a challenge for them to develop, maintain, and understand relationships. So some of them, they are always isolated. They can't have a friend for a long time. They can struggle. But if we understand them, remember, many autistic people live successful lives. They've got children. They live in families. Some autistic parents have got good, big families. They go to work. They do everything. But it all comes to the issue of understanding one another. If you understand in autistic people what they want, what they do, communication is easily facilitated in that way. And the second category again, restricted and repetitive patterns of behavior, interests or activities. Some just like hand flapping, toe walking. That is if they're children maybe, and you think, why are they doing that? Playing with gadgets in an uncommon way, such as lining up objects, or in your office, if you work with one autistic person, they want to line up objects, and you may not understand that. And then you can come with your own different interpretations there. But to them, they like doing that. Speaking in a unique way, such as using odd patterns of pitches in speaking or scripting from favorite shows, something they've watched, they like imitating that. Having significant need for a predictable routine or structure. That's a major thing again here, that just changing the structure, the way the room is arranged, where they sit, the structure of the day, tend to get up, to go to work, changing that routine can actually affect them a lot. Exhibiting intense interest in activities that are uncommon. That's similarly, when I say that, like putting gadgets, lining them up, to people who are not autistic, all these things are not very common. And again, another big thing is the sensory issue. They experience different sensory issues, much different than the way non-autistic people do. Some of these sensory issues are so much overwhelming for them, or in some cases underwhelming. That is, it can be unusual, such as an indifference to pain, temperature, excessive feeling of pain, or not feeling the pain. It can be any way. Excessive smelling, touching of objects. Some, even the feeling of fabrics on their body can cause problems with them. Fascination with lights and movement, and being overwhelmed with loud noises. I remember one autistic young person telling me that sound that was happening in one building, to us, it was not even loud, but to that young person, that sound was like loud explosions. And then putting his hands on his head, banging his head on the table, and All of us, we could not understand it, why that was happening. But inside him, a lot was happening. The sounds were like explosions. So we need to understand that as well. And many autistic people have different ways of learning, paying attention, or reacting to things. And remember, signs of autism begin during early childhood and typically last throughout a person's life. And I should have mentioned early on this presentation that at the moment, autism has got no a medical cure. So autistic children or adults might not point at objects to show interests. For example, not pointing at an airplane flying over. Not look at objects when another person points at them. Have trouble relating to others or not have an interest in other people at all. And this can be a problem again in terms of relationship. Understanding why some autistic people are not getting engaged in a conversation. Why are they aloof, distracted, not involved, or just going in a corner, sit by themselves? And some of them avoid eye contact and they want to be left alone, which is fine if they want to be left alone. Some have trouble understanding other people's feeling, which I'm going to talk later on the next slides about feelings. Others prefer not to be held or cuddled. Again, remember, I spoke about sensory issues. Maybe just holding them is very uncomfortable for them. And some appear to be unaware when people talk to them. So if it's in a clinical setting as well, they are not responding to you, you really need to understand why that is happening. It could be due to the autism as well. And some can be very interested in people, but not know how to talk, play, or relate to them. Others can repeat or echo words or phrases said to them, have trouble expressing their needs, and using typical words or motions. Others just don't want to play. They don't feel like doing that. If they're children, they don't want to do, you have a young child who gets a doll, play with the doll, pretends feeding the doll and so forth. But if that child possibly doesn't have that interest at all, which is what you expect at that age group, and others repeat actions over and over, have trouble adapting when a routine changes. I've mentioned that as well. And I spoke about sensory issues, including smell tests. So in context now, most autistic people are adults now, although a lot of research is talking about children and autism. But you have to remember those children, they get to be young adults, then eventually they become adults and move on to old age. And autistic people, some of them, if not most, do have an intellectual disability and are unlikely to be undiagnosed because some could have just gone through the system undiagnosed. Of those known to services, many have a wide variety of co-occurring physical and mental conditions. This association means that for many, their first professional encounter will be with adult psychiatry. It could be in a rehabilitation, forensic, old age, liaison, or some other specialty. And some will have problems that relate immediately to autism, but most will come with the symptoms of an assortment of psychiatric disorders. So the context will complicate their presentation, and also it will complicate the management. Further, this includes where and how they live, the people and services available. So this actually means that clinicians need to get in touch with home, with parents, schools, and other services as well to get a bigger understanding, a bigger picture of this autistic individual they are trying to help. And the prevalence of autism now is 1% of the general population, of whom most are adults now. But this 1%, it goes up because although autism is present in that 1%, it is encountered in 3 to 5% of mental health services. And because of this, that's a huge number when you look at the population in this country. And its presentation and management being affected by their co-occurring disorders. So these co-occurring disorders will color or will make it not very clear. For example, their communication, flexibility, and ability to engage in the clinical process. So autism may go unnoticed, or conversely, its characteristics may be so amplified by stress that everything is ascribed to autism and any other issues are missed. So again, here as clinicians, or if you work with autistic people, you need to make a very clear line to understand so that you can separate autism from the other conditions. So there's a limited ability to take part in meaningful conversations. I said that earlier. And so on this slide here, I'm just, reinforcing what I've said earlier again, although it's from a different code, but it's the same thing I've said earlier. So what should the clinician do now? Wherever possible, it is essential that the clinician get accurate accounts of the individual's social relationships and interactions in different settings, and particularly how they manage more demanding situations. Now, communication differences and difficulties as well. And I've mentioned earlier, the lack of communicative gaze is distinct. Having that persistent downcast gaze that may be seen in shyness or depression. Speech may have a pedantic correctness. I've mentioned that earlier as well. And difficulties with nonverbal expression can show in an unusual use of gaze. We discussed about them being expressionless and not able to understand maybe even the gestures other people are making. And the mismatch of emotional expressiveness is dangerously misleading. So what I'm saying here is anxiety can be masked by a fixed smile, an annoyed frown, or an angry response, any of which can lead to serious misunderstanding. Many appear relatively impassive, giving a matter-of-fact account of their predicament without the facial expression, gesture, or other signals that might indicate their distress. Others try to blend in with what goes for normal in their culture, may use exaggerated expressions and gesture, with the result that they appear histrionic or just not right. So there can be equivalent difficulties with nonverbal comprehension, and an autistic person unable to interpret a speaker's facial expressions or tone of voice as indicating irony, sarcasm, or humor can be left to take what is being said literally, because you could be joking with them, but they could not take it as a joke. That's what I'm talking about here. So what should the clinician do in this picture? Verbal communication is usually less problematic, particularly if the material is written rather than spoken. So if you're able to put something down for them to read as well as you have your verbal communication, that would be very helpful. But however, the clinician should not assume that because someone can cope with a structured question and answer dialogue, they can cope with informal conversation. The clinician must guard against these and check regularly that they have been understood. So you need to check both ways, written and verbal, just to make sure that you and the autistic person, you are speaking the same thing and you are agreeing on the same thing. So I'm going to talk about emotional blindness of Alexemia. So Alexemia is associated with autism and can limit the individual's ability to recognize, label, and describe their own emotions. And I quote here Serran, who said that sometimes I work with children and adults who can't put words to their feelings and thoughts. It's not that they don't want to, it's more than that they don't know how to. So a few examples those with Alexemia experience is difficulty identifying different types of feelings, limited understanding of what causes feelings, difficulty expressing feelings, difficulty recognizing facial cues in others, limited or rigid imagination, constricted style of thinking, hypersensitive to physical sensations, detached or tentative connection to the others. And the result is that the individual, preoccupied with experiences that pass unnoticed by others, can appear distracted, daydreaming, or even hallucinating. The degree of sensitivity varies, but can be so intense as to produce overwhelming and incapacitating distress. A heightened awareness of certain tastes and textures may lie behind very selective eating, which could lead to eating disorders as well. There's a lot of research going on, researching, on the intersectionality of autism and eating disorders. So, unusual sensory responses. Autistic people may be more sensitive to a variety of stimuli. These may be drawn to or repelled by different sensations, which can be as diverse as certain sounds, patterns of light, repetitive movement, clothing textures, minor anomalies such as room smell, a net of cracks, the hum and flicker of neon light. So what this simply means is to make sure that the environment we are going to work with autistic patients or any autistic individual should not have this stimuli that could trigger, anxiety, depression due to lights, due to sound, smell, bright colors, anything. So this can result in someone set in their ways with fixed routines and a strong aversion and disproportionate distress towards change or novelty. So I'm talking of inflexibility here. Yeah, we can say they are not flexible, but that's how they want structure. And this differs from obsessive compulsive behavior in that the autistic individual does not feel the behavior to be alien and there's little desire to change, particularly if it is something they enjoy. So they could be doing something over and over and over and they enjoy doing that, which to us could be like being inflexible because you want them to stop, but they don't want to. They enjoy it. You see, so certain behaviors are done because they like doing them. But again, it could be a response to the stimuli, to the sensory issues. As I said earlier, you could see someone may be tapping a table continuously, yet they are trying to block some sound coming from somewhere in the room disturbing them, and they're trying to concentrate on tapping the table, trying to stop that disturbing them. So what to watch in that? Autism may mask or mimic a wide range of psychiatric symptoms. So the mental state examination should confirm that the symptoms are what they seem. I spoke of Alexemia. It may hide anxiety or depression. Hallucinations may be inferred mistakenly in someone who is detached or who suddenly becomes distracted. A confident claim of many friends may be misleading, as for example, closer inquiry might reveal a concept of friendship measured by Facebook friends and work acquaintances. But again, Facebook friends, these friends are virtual. So if they say I've got hundreds of friends, and you might think, wow, yeah, that's okay, they're socializing, okay. But they could be talking of Facebook friends, and yet they have to go home, they're lonely. There's no friend, there's no one to check on them. So in all this, the clinician needs to find a balance between overlooking autism and seeing it all around. And there's cultural interference as well. You know, we have got some institutions like a prison, military, or religious establishments which have got a predictable routine and a social hierarchy. So it's so easy for an autistic person to follow that routine because it's done every day. Autistic people like routine. They like structure. So they can do that so well, extremely so well, that the autism cannot be seen at all. Or in their communities, there could be other disabilities as well, such as hearing or visual impairment or intellectual disability as well. You know, these co-occurring conditions. And again, it could be very difficult to pick on autism there as well. So in judging the significance of a symptom, the clinician will need to take into account what is the norm of that group. So in this case, it's so important clinicians to understand the culture of the person you're trying to help. Because some cultures, they stereotype autism. So the autistic person might understand this is not accepted in the culture, and hence they can mask it from you. Maybe even the parents could not be so frank with you and open with you because of the stigma that sticks to autism. So it could be a cultural thing, it could be a religious thing, and so the clinicians has got a lot of work here to do to be able to get to the bottom of the issue. So access can be helpful by staff and public education. We have to remember that the use of online booking and communication is helpful, and a hospital passport, which is a document carried by autistic person, which sets out their characteristics and needs. That is very good. I've encountered many autistic young people whom I work with, and they've got these passports. The passport can actually tell me what they like best, where they want to sit, how should I talk to them, because their GPs, their doctors from the clinics, from the hospitals, they've gone through different services, and this has been documented. So for me, it's so easy for me to get along quickly and understand. So in terms of psychiatric management, the presenting difficulties of an autistic individual, including their characteristics, will be improved by anything that reduces their anxiety or increases their physical comfort and sense of well-being. So if you use the hospital passport, You are not going to interrogate them a lot about what they like, where they want to sit. You may already know that they've got sensory issues. Let's say it's loud music. So you need to turn your music down because you're reading the passport. In that case, you're making them comfortable. Better communication and social understanding, which I've mentioned earlier as well. Improved environment, which is familiar and predictable with the reduced sensory stimuli. It is very helpful when they visit hospitals, when they come for interviews, try to use the same room so that they become familiar with the setup. That will be very helpful. And access to services presents a hurdle to many autistic people, and some just coming out of their house is a challenge, particularly if they live an isolated life, because there's a lot of unfamiliarity, unpredictability, or difficulties for them to communicate around. Even getting a bus ticket, jumping on a train, all those things, it needs, you and me, we do it naturally because we can just go along the challenges, the programs, but they really want things that are predictable. Even using a telephone, which they don't use all the time, first time it could be challenging. And so the autism-friendly psychiatric unit should have an area adapted to autism. Of course, this could be challenging, looking at that you could have not that area in your building. But again, you have a choice of looking for an alternative meeting place where the environment is conducive, suitable for both the constitutional needs of the individual and their psychiatric disorder. Staff, buildings, and programs should be structured, predictable, and calm. And here we are talking of, it's more about people who design buildings, or when you are designing buildings or your environment. We call this universal design. This is one of my master's thesis I did for my MA at University of East London, which was looking at universal design so that disabled people can access anywhere, any building they want to. Because if we don't have universal buildings, what we are actually doing as a society is to disable them. Hence, them themselves, they are not disabled. We are disabling them as a society. So we need to have conducive, suitable, universal design structures, buildings, so that they do not have a problem. Stimuli should be of low intensity, which I've discussed about already. There should be regular routines, use of clear and visual communication, restricted number of people, staff and patients, so that the individual can get used to them, so that they know their staff, each other, it really helps them. And again, there needs to be an emphasis on regular staff training in autism to avoid stagnation, on the development of relationships with other specialist autism services, and on input from autistic people. So finally, you can see that I've written some articles on autism. If you really want to follow me, you can read my articles, as you can see there on ResearchGate, where I post my articles. And you can also follow me on Twitter. And hopefully, I would like to think that this has been very helpful, and would like to thank you for taking your time to listen at this presentation. Thank you very much.